Chronic fatigue syndrome and ME. This is a controversial area. In Europe, the most common term is ME, and it stands for myalgic encephalomyelopathy, more often than not. In this country, it's chronic fatigue syndrome. Chronic fatigue syndrome is a perfectly terrible name, and ME is not all that great. At least it sounds way, way worse. But the bottom line is it's the same darn thing. I often get really angry mail from people in Europe because we in the United States claim that ME and CFS are the same thing. And frankly, CFS is our name for the whole spectrum of disorder. And ME is diagnosed a little bit differently, a little more emphasis on severity. Is maybe the sickest end of chronic fatigue would certainly fit under ME. But in the end, in this country, ME and CFS are the same thing. And we're waiting for better names because the names are perfectly horrible all around. So CFS is way worse than ME in terms of a bad name. Under this umbrella of ill people that are defined by profound fatigue and then a number of symptoms that encompass pain, inflammation, poor sleep, and exercise intolerance and exhaustion and relapse after exercise. Under this umbrella of that, there are possibly subsets. We debate this a lot in research because in research, you might have one group finding one thing and another group finding the other, and we argue over whether or not we were actually looking at the same patients to begin with, apples and oranges in the same basket. I notice in my clinic, because I'm a clinical immunologist, that I tend to have people with a lot of inflammation and immune problems, and that sort of makes sense. People would come to an immunologist for that. A colleague of mine who's a neurologist says that his clinic draws in more of the cognitive dysfunction chief complaint, and that might flavor what he sees in his population. In the end, it's going to be biomarkers that tell us how many subsets there might be, and if there's one sort of big enveloping illness with different subgroups underneath it, or if they're actually separate illnesses, different types of illnesses. We also find that, and you know this because you have chronic fatigue syndrome, but there's remit and relapsing periods, and a person can look pretty ill one day and halfway decent, 2 or 3 weeks later. I saw this last weekend a patient came to a conference we gave that looked fabulous that I'd seen 2 weeks ago, and I was so worried about her that I was thinking about putting her in the hospital. So the illness itself has its own remit and relapse kind of times, and the patient can look quite different from week to week or month to month, and that makes it more complicated as well. When we're diagnosing chronic fatigue syndrome, we're focused initially on the rule-outs. Well, that's an interesting term, rule-outs. We've diagnosed this, we've defined this illness by symptoms. You're profoundly fatigued and you have at least 4 of these 8 symptom criteria. But a lot of illnesses can have profound fatigue and have a lot of symptoms associated. So we have to rule those illnesses out to know if this is actually a chronic fatigue syndrome case. What kind of rule-outs might there be? Well, I say it's the textbook of medicine. You could have a person coming cold off the street with just these symptoms, and there could be a neurologic problem, there could be an infection, there could be cancer, there could be a profound emotional problem, there could be any number of potential rule-outs. But a decent doctor doesn't need to spend a ton of money doing the rule-outs, because usually taking a history, doing a good physical exam, and just some basic blood work will rule out anemia, thyroid disorders, chronic active hepatitis, a bunch of stuff that can look just like chronic fatigue syndrome. And then on physical exam, you can usually figure out the rest. So the diagnosis is both symptom-driven and driven by your history, your physical exam, and some basic laboratory work. Once you have the diagnosis of chronic fatigue syndrome, we have some other studies we like to do to see whether or not there's something reversible that you can fix. In general, in medicine, we don't like to do a bunch of studies unless we're going to do something with the answer. You know, it's great to know a lot about somebody, but if you're not going to try to fix something, you don't want to spend a lot of money on the workup. And so there's some controversy over whether or not we should be drawing, like I do a lot of immune testing and viral serology testing, because I think it does drive my decision process. Being an immunologist, of course I would. But there are some people that say that's not necessary, that the diagnosis is the diagnosis and you can't do anything about it, and da-da-da-da. And so there's some controversy, particularly among the third-party reimbursement people, your insurance company, about whether or not we should be doing a lot of tests after that. I think some are very practical. Sleep studies. If a patient has non-restorative sleep, and that is one of the basic defining characteristics of chronic fatigue syndrome, you can be pretty sure a person will feel significantly better day by day if they had better sleep during the night. For two reasons. One is, of course, sleep is restorative. That's what it's supposed to be anyway. And the second is, during that restorative sleep, during the deepest stage of sleep, you release some hormones that are terribly important to healing, restoring tissues, reducing inflammation. A lot of stuff's going on in your brain at night, and most of it's regulating your hormone balance, or at least some of it is. So a person that has consistent, good, deep sleep does better in this illness than a person who does not. It doesn't cure the illness. If it cured the illness, it would have been just a sleep disorder to begin with, and the sleep doctor would have taken care of everything. But it does make a person with chronic fatigue syndrome feel significantly better. So I actually do order a lot of sleep studies. I've done this because, hey, I've been doing this for 25 years now, and I've missed a lot of reversible conditions. I feel kind of guilty about that in retrospect, but there's a certain bias in medicine. We presented a paper recently that said 40 to 60% of chronic fatigue patients over the course of their illness will develop, at least at some level, some sleep apnea. Now that's disturbing, because here you are, you're cruising along with this chronic illness, you add on sleep apnea, who's going to notice? You're profoundly fatigued. So here's this very reversible, potentially dangerous complication of this illness that, that needs to be watched for and assessed. So I do use sleep doctors to help me both diagnose and manage the sleep disorders. And I try myself to pay very close attention to sleep on each and every visit. Other diagnostic tests that we might do. A lot of patients, about 60% with chronic fatigue syndrome, have this condition that allows their blood pressure to drop very precipitously. All of a sudden they have very low blood pressure. Some of you call that a crash. You might not actually pass out, but you come very close to it. A classic example would be someone who has about 15 or 20 minutes of upright time. So they can get in their car, they can drive to the grocery store, and they get about the third aisle or so, and they have this sense that if they don't sit down right now, something bad's going to happen. You'll find them sitting on the floor of the grocery store. Some of you have had this happen to you. And that is your blood pressure suddenly falling, and you don't have enough blood flow in your brain to keep on going. You got to wait a little while and let things catch up, and then you can get back up and hobble out to your car and abandon your grocery cart and go home and lie down. Does this sound familiar? Well, there's some studies to figure that out, and I typically do the cheap thing first, which says send somebody home with a blood pressure monitor and have them do logs of their time when they're up and down and when they suddenly crash to check their blood pressure, because also a blood sugar at the same time might do the same thing, a drop in your blood sugar. So I often send them home with a finger stick gadget and a blood pressure monitor and try to capture a crash. But a laboratory way of doing that is typically done in a cardiology clinic, although some doctors can do it in their office as well. It's something called a tilt table test, where they put you on a tilt table. It sounds very innocuous. Put you on a tilt table, put you upright, almost upright. You sitting on this table, or standing on this table, and your blood pressure is being monitored and your pulse is being monitored, and you're looking like, oh, this is dumb, I'm standing on this table, and then all of a sudden, boom, you have a crash. And it's a little more exaggerated than it would be in the grocery store, because you're not using any of the muscles in your legs, and your blood really pools a lot more in your legs when you're on this table. So it's really a dramatic event. Doesn't feel good, but it proves the point. And in a kind of cool way, you can repeat it, taking this medicine or that, or some IV fluids or whatnot, and try to find out what might fix it. So some doctors, again, not all of them, in fact, not many of them, will use the tilt table not just to diagnose, but also to guide their hand in what the exact right therapy might be to prevent that. And they're the ones you're looking for. They're out there, they exist, but they're hard to find.